Good morning. So here are my disclosures. The closest to a for-profit is the Merck Foundation, which is a philanthropy funded by Merck Company. And then most of the other things are a variety of associations. I do a lot of work across the spectrum, from patient advocacy groups, professional societies, the government, a lot of the creditors, including CMS. So I'm going to first praise this roundtable and the NCQA conceptual framework. I'll spend most of the time talking about trying to place the overall framework within this broader context of efforts to reduce disparities, in particular care transformation and payment reform. I've actually loved the conference so far. That I think there's a lot of great ideas. I think a lot of it actually is all on the same page. I'm actually going to try to sort of put together what we've heard so far into a even more synthetic whole, which I hope will spur the conversation. I'll end with some recommendations on ways to link your efforts with some of these broader initiatives and trends. So briefly, I think you guys are on the right track. I really like the paper also. I'll mention a couple things about why in particular. I was at the roundtable meeting in Irvine maybe 2 or 3 years ago, and I remember at that time too there was talk about silos, both silos among your 3 topic areas, as well as silos between like cultural competence and then the rest of disparities efforts. I think this particular meeting today shows a lot of advancement in terms of breaking down those silos and really integrating into what I think is ultimately going to change equity, which is this broader perspective in terms of policy change, payment, implementation science. I also like that it's really clear how like your efforts in these areas, there's some obvious links now to policy and change levers. And so all to say that I think you're really on the right track here. So I'm going to now shift into the segment where I talk a little bit more about this broader framework and then how I think that your efforts fit into it. The first part will come from a lot of the Robert Johnson Foundation work we do. We run one of the foundation's major equity programs over the past decade or so and developed a roadmap, which was actually cited in NAM's Systems Practices report recently about best practices for caring for at-risk populations. So in some ways too, like you think about achieving equity, one of the big challenges is there's no magic bullet. So for anything, including cultural competence and health literacy, you can't just sort of magically roll out like a model program and think that that's going to solve the problem. The challenge is that it's a systematic process that, as others have mentioned, there first has to be awareness and prioritization of achieving equity, the tailoring of a solution to the local context. So again, the off-the-shelf solution just doesn't work. An iterative quality improvement process that does address those specific barriers and facilitators for your local situation, and really utilizing the principles of implementation science. What we found, though, like when we provide technical assistance to organizations, is if you just tell them, well, there's no magic bullet, it's a systematic process, they don't like that. And what they want is that understanding that it is a process, but also they do want a menu of evidence-based interventions that they can think about as a starting point and adapt for their own purposes. So you're not just basically saying, well, it's QI, solve it on your own. There is a pretty good evidence base for a lot of what can help reduce disparities. So we have a 6-step roadmap I'll go over real quickly. This first part about recognizing disparities and committing to reducing them, I think of in 2 different domains. One is the reporting of stratified performance data, stratified by race, ethnicity, language, socioeconomic status, et cetera. The second is where I think cultural competency fits in, that is critical then for getting people to truly prioritize equity, which we'll talk more about in a moment. We talked about second about the QI infrastructure and process. The third is one that I think nationally we don't do a very good job at, and that's making equity an integral part of quality. So in other words, as opposed to, so actually NAM, for example, a lot of people don't realize that in 2010, NAM revised their quality framework. So equity used to be one of the 6 pillars of quality. No longer. It's really a cross-cutting dimension that then cuts across all the other dimensions. So it's a fundamental philosophical change. So it's supposed to be marginalized, like you do your community fair, check mark, equity done, or cultural competency training, check mark, equity done. It's how do you think about equity in all of your quality efforts? How do you improve care for all your patients constantly? Designing intervention for 5, implementation science, 6, sustainability, which really, when it comes down to it, becomes critical, because unless there's sustainability, it's really sort of moot. So the sobering thing is that when you review the literature, and we reviewed like over 400 equity interventions, there's not a lot of common things about what reduces disparities. Here's the best we can come up with. Multifactorial interventions, culturally tailored QI, team-based care, involving families, community partners, as others have mentioned, community health workers, interactive skills-based training as opposed to didactic lecturing. So again, not a lot of common themes. So I'm going to segue into this issue about payment and value-based purchasing. And so whenever we've worked with frontline organizations, whether they're like academic centers like the University of Chicago, or even the most mission-driven safety net providers, I do a lot of work with federally qualified health centers, for example, they all say the same thing, that at a certain point, no matter how good the mission, how worthy the goal, such as equity, there's only so much that they can do because of the way they are paid. They have to eventually balance the bottom lines, ergo the importance of payment reform. So motivation, I tend to think of on two different domains, intrinsic and extrinsic. And I'm going to go out on a limb a little bit here, and I gave Bernie a warning. I'm going to embarrass him a little bit. So intrinsic motivation is still the most important thing. So in other words, doing things for the right reason and professionalism. I met Bernie for the first time about a week ago at an ACP immunization equity meeting. So I don't know him very well, but it was clear within like the first 2 or 3 minutes of meeting him and hearing him speak that he's got it in terms of like the professionalism, that sense of inner drive to do the right thing. So in one sense, this is great. It's great to have people like Bernie leading this roundtable. But on the other hand, it's not great in that this should be the norm. And so there's something that we all need to help nurture. And so in some ways, I think some of the most important parts of cultural competency training is basically building upon that intrinsic motivation. However, that's not enough. And in my story about like the business case for safety net providers or academic centers, the same thing, that at a certain point, there's got to be an economic bottom line business case. Yolanda said this at the end of her talk also. So the finances have to align with what is the goals of this particular round table. When I think about payment and value-based purchasing, I can think about like 3 different buckets in terms of equity. One is pay for performance, so you're incentivizing a specific action, the provision of interpreters. A second is like infrastructure. So, for example, how do we make sure that for global payment programs, enough of that global money goes towards funding the preventive and primary care that currently really isn't incentivized in much degree? So something like community health workers, which typically is not funded for. So how can that be? How can we ensure that funds sort of flow that way? The third and related is then the social determinants of health, population health, which we haven't talked about too much yet. And so like there are a lot of innovative things happening now in terms of like integrating the non-health and health sectors like housing to try to improve equity. So macro, we've heard about this in MIPS, quality payment programs, alternative payment models. They all have requirements in terms of quality metrics, health IT requirements, cost accountability. But when you look at the regulations, the striking thing is that, where's equity? I think Jessica was being very generous when she said that there's equity measures within the various MIPS programs and all. I don't really see it. And so in some ways, this is the huge issue, that because, frankly, people at CMS, a lot of really good people, and they have a lot of competing demands. And I think really the issue is that it just frankly has not been a high enough priority for all of us, right? Otherwise, equity would be in there. So creating a business case for achieving health equity. I'm going to go through 6 things really quickly, different ways that CMS and other payers can align the financial incentives. We talked about stratified performance data. This issue about paying for reducing disparities, in some ways that was the implicit theme for a lot of Jessica's presentation. These are in some ways equity accountability measures, which I don't think right now are embedded in almost any payment program. It still boggles my mind why there aren't equity accountability measures. I was on like NQF committees for years, and this was like my theme, pound the table, like why aren't there equity accountability measures in CMS other payment programs? They can be like some of the measures Jessica talked about. They can be things like how do you incentivize the reduction of disparities, explicit measure. Why not? Strengthen incentives for prevention, primary care, we already talked about that, the intersectoral partnerships, social determinants. Aligning measures, taking care of the safety net. The safety net will need special attention. Something like risk adjustment issues in terms of social risk factors, demo projects. The key underlying bottom line is having an explicit equity lens, basically thinking about in the correct design of our payment programs, our quality improvement programs, how to reduce disparities, as opposed to after the fact looking for unintended negative consequences. So I'm going to segue into this segment on NQF. And so Kara James, who's still here, yep, has, under her leadership, has funded the NQF Disparity Standing Committee to do some work in this area. Sarah Shirley from CQA here is on this committee. Ignatius Bowes from helping staff has been incredibly helpful. And so you see here, there's on the top bubble your typical health equity measurement cycle in terms of coming up with measures, measuring disparities, implementing QI approaches, and then this continuous cycle. You see the things that are new down here are like at the middle you have this blue bar, incentivizing the reduction of disparities through measurement. Some of the things that I just talked about, ultimately leading to improvement in the disparities in healthcare, elimination of disparities. And so a formal effort by this multi-stakeholder coalition to try to think about using performance measurement, linking to payment to try to reduce disparities. And so you're going to see that a lot of this draft equity measure domains for NQF have come up for disparities, a lot of overlap with the Jessica's paper and the things that we've been talking about. What we try to do in some ways is come up with a conceptualization that sort of links the different steps you need to do to reduce equity. And then we're thinking about these are being equity domains that we need to come up with measures. Some already exist, some need to be developed. So others have talked about the need for a culture of equity. I think Yolanda very eloquently talked about how you got to have an organization where equity is the high priority at the highest levels. It's got to be cultural competency throughout the organization, the leadership, the staff, the clinicians, workforce diversity. One of Marin's points was not blaming the individual, so the awareness of historical cumulative structural disadvantage, why the disparities exist, and that type of appreciation. People need to advocate for equity within their organizations. There needs to be a safe and accessible environment within healthcare organizations. It's not just culture, it's a concrete structure. The capacity and resources to do things like identifying social risk factors, reporting stratified performance data, having a hot name here, learning systems, a QI with an equity lens, using this type of data, good population health management, community needs assessment, adequate policies and practices, transparency, public reporting, accountability. So how can we develop measures that organizations be accountable for these different domains? Equitable access to care, different domains such as availability, accessibility, affordability, convenience. Equitable high-quality care. So both absolute attainment as well as continuous improvement across these structure, process, and outcome measures stratified by the risk factors. Again, evidence-based interventions. So are people using team-based care, CHWs, culturally tailored interventions, support for self-care? Others have alluded to collaboration, partnerships, and linkages for equity, a variety of different domains, so integration of medical, behavioral, oral, other health services. I mentioned collaboration across health and non-health sectors such as education, criminal justice, public health, housing, community health system linkages, community engagement, social capital, social cohesion. So when I think about like this particular round table and this link to policy and change levers, this issue about education is necessary but often insufficient alone for behavior change. So let's need to link to the policy levers, link to payment, link to implementation issues, these ongoing efforts. I think like over the course of the morning so far, I mean, clearly, I mean, you look at my bullets that the roundtable can go into these issues of language, cultural competency in much more sophistication and detail. I do see a potential challenge for you moving ahead. Some of the discussion is sort of this classic tension between what is right for patient care and then some of the trade-offs that need to occur, as Jessica mentioned, for performance measurement and all. We're thinking about things like cost, feasibility, data collection and all. I see that tension already within your roundtable, and I would just recommend that you keep in mind and don't let the perfect be the enemy of the good. And the standards for something like a clinical practice guideline are different than the standards for something like a performance metric to be used for a payment and accountability program. Over the past year, I've gotten in the habit of ending my talks on disparities with a little bit about leadership and advocacy. I had a blog piece that come out maybe half a year ago with the bizarre title of Moonshots, Opioids, and Incentives, which is the first and last blog piece I'll have that was accompanied by a picture of a NASA moonshot. But when I thought about this issue, like, why do health disparities persist? So you can think about like structural determinants, you can think about implicit bias, you know, all these other causes. But when it comes down to it, I came to the conclusion that a simple answer is that our country tolerates them. In other words, again, if it's high enough priority, we would be making more progress. And the way that we pay for medical care largely does not support efforts to achieve health equity. So I put in another paper, I believe movement advocacy can break down ingrained structural barriers and policies that impede health equity. And that's one of the roles for a roundtable like this, basically to work on some of these structural policies and regulations that impede health equity. While at the same time, clinicians, healthcare organizations, and advocates build trusting relationships and resolve conflict with mutual respect and honesty at the frontline level. We must combine advocacy and relationship building to end disparities. Achieving health equity will require policy changes, again, this roundtable and its expertise and influence, and then personalized clinical care and organizational transformation that are dependent on goodwill and trust. So in other words, equity must be a priority in all health policy issues. The older I get, the less patient I get in terms of these policy regulations that, frankly, shouldn't be the way they are. And it's partly because of us in terms of not making it a high enough priority. I'll end with this quote that leadership matters. It is a professional responsibility as clinicians, administrators, and policymakers to improve the way we deliver care to diverse patients. We can do better. Thank you.